patients, but also on the dinner where we can have some small group sessions between more intimate sessions with the doctors and the staff. Quickly, announcement items. In 2018, we started our new Coquitlam clinic. Those of you who work around that area may have seen our new clinic open in 2018. It's going very well, but it is also very slow. So we're just breaking into a new market. And if you do have colleagues, friends who own clinics, make sure you let them know that we'll appreciate their referrals over in Coquitlam. At least half the audience, maybe half the audience here is in Abbotsford. This is a new location for us. I was in the old location year. I made myself a promise that when I started my last location, we outgrew that location in about two years. I was like, for the next 10, I better get a bigger location. So thank you for coming to the new location. We do have a number of new doctors, so we'll talk about that in just a second. We also have new speakers. Please mingle, please talk to our staff. We do have a lot of new people here, so you might hear new names, new faces, so that's exciting. A couple of things that they wanted us to mention, co-management fees. So we do have a fee that we coordinate with our optometrists. Now that we're doing a lot of ICLs, RLEs, and LASIK, we do have, if you're interested in this program, please let us know. Either as a clinic, definitely have somebody coming out to talk to you about that. And the other thing is, we're going to talk about this in my presentation, co-management arrangements. Some clinics would like to do a lot of co-management, medical clinic or private patients. If you're interested, we just left it open to say, if your clinic or you as a single practitioner are interested, please contact us. We do have a program where we can co-manage with your clinic. And we'll touch on that a little bit on my presentation. And, oh, Phil, do you have the clicker? Yeah, thanks. Okay, good. There we go. Most of you do know that we have 3 locations now. Half of us is sitting at the Surrey location, so most of you have maybe seen the Surrey location. This location in Abbotsford is new, and then we also have a Coquitlam location as well. All 3 locations have been built to sustain a clinic as well as a surgical center eventually. Currently, our only functioning surgical center is in Surrey. And we have a number of doctors that probably won't need a lot of introduction. But what I have here is just a quick reference list as to who is doing what or specializing in what. So for myself, I like doing intraocular work. I do a lot of eyelids as well. Dr. King is doing a lot of refractive procedures. Dr. Payne also doing a lot of refractive procedures. Karen Moosberger is doing a lot of clinical as well as some limited eyelid surgery. And our newest doctor, Dr. Klesse, has a focus on oculoplastics. So he's based out of Surrey and Coquitlam, and he's doing mostly cosmetics and eyelid surgery. And I think that's going to be what his focus is on. Good. And medical optometrists, we have 3 so far. Most of you have met Dr. Culver Dollywall, who's standing in the back there. Aaron Chiam is somebody who's working with us in Surrey and Coquitlam. And then our newest member is Dr. Kelly Tokar, which some of you may know as well. Okay, good. Any questions before we start with Dr. Payne? This is us at Tofino 2 weekends ago. That's my daughter. She's 3. Her name's Aubrey, and this is Julia, my wife. Okay, I'll hand it over to you, Darren.
Okay, thank you, Gabe. So good evening, doctors. I'm Darren Payne. I'm an ophthalmologist. Been here for this is my third year now. I work at Surrey and also the Abbotsford Clinic. And I used to work in the Coquitlam, but not anymore. Dr. Classy took over that clinic. So tonight I'll be entertaining you on visual field defects. I thought that was kind of apropos. And I think it's a good review for yourselves and for myself as well. We get a lot of referrals for visual field defects. So what's the definition of a visual field? It's the area in which objects can be seen in your peripheral vision as you focus on a central point. And a visual field defect, of course, is a part of that field of vision that is gone. So a scotoma, basically. And there are many causes of visual field defects. I'm going to mention just a few, glaucoma being probably the main one. Some neurological problems as well, tumors, MS, strokes, migraines. We have injury, we've got chemicals, we've got medication, Plaquenil, we've got hereditary diseases as well. So there's a bunch of issues that will affect your visual field. So if you look back how the visual field is created, you've got your eyeball, and in the optic nerve, you probably remember that your temporal fibers keep going straight, and your nasal crossover in the optic chiasm, which is right above the pituitary gland. So any lesions that would affect the pituitary gland will grow superiorly and affect your field of vision. So these then become the optic tracts. So there's one axon, one neuron that goes from the nerve up to the lateral nucleus of the thalamus, which is here. So you have to remember that any lesions from the LGN forward will create retrograde optic atrophy, okay? And lesions posterior, which is the second neuron from the LGN to the visual cortex, will not, okay? And as you're aware, your left visual cortex takes care of your right hemifield and vice versa. So what would some lesions of this pathway give you as far as visual field loss? If we look at the macula, you would obviously any maculopathy, whether it's macular degeneration, Plaquenil, cone dystrophies, you would get a relatively small central scotoma, and it's obviously not necessarily a round pattern, right? If you had an optic nerve defect, such as optic neuritis, you will get a bigger central scotoma, okay? And if the whole optic nerve is affected, then the complete loss of visual field. I had a patient a couple of weeks ago who had a meningioma around her right optic nerve. She's NLP, and of course, we didn't do visual field, but obviously the visual field is gone in this case. If you have a lesion of the optic chiasm, typically you would get the bitemporal hemianopia. It's not always this obvious though. And you can have a lesion also in between the nerve and the optic chiasm. It's called a junctional scotoma, so it's not a full bitemporal hemianopia. If you go further back around the optic tracts, then if you have a lesion that basically encompasses the whole area, you would get a contralateral homonymous hemianopia. Further past the LGN, they split into a superior and an inferior portion, so you could get a contralateral superior or inferior. This is not quadranopia, it's quadrantanopia, by the way. And posteriorly, if you have a lesion of your visual cortex, your occipital lobe, you would get typically a homonymous hemianopia with usually macular sparing, and I'll go over that a little bit later. So again, these are various causes of visual field defects. You got your neurological, strokes, tumors, IIH, which is idiopathic intracranial hypertension. But this is long-term, okay? You wouldn't have a visual field loss on a short-term issue. Migraines sometimes could at least temporarily give you field defects. They tend to be bilateral, and they're, again, relatively symmetrical. You can think of your bitemporal hemianopia, whether it's homonymous or bitemporal. Of course, optic nerve lesions cause visual field defects, and the main one is, of course, glaucoma, and I'll go over the glaucoma a little bit later. Optic neuritis, which tends to give you a central defect again. Non-arteritic ischemic optic neuropathy, temporal arteritis or GCA as well, Leber's optic neuropathy. So there's a whole bunch of lesions that would create optic nerve lesions. Retina problems can also give you visual field defects. Of course, usually it's going to be one eye. There, you can think of retinal detachment or a large chorioretinal scar. These will give you, of course, an irregular visual field defects. RP, which is retinitis pigmentosa, would affect both eyes. It would give you tunnel vision towards the end of the disease process. The macula also could affect your visual field. Of course, it's a much smaller visual field defect. Macular degeneration, first one, plaque O'Neal, again, some cone dystrophies as well. The eyelid, ptosis, dermatochalasis, and as you're aware, we use the visual field defect as a reason to do bilateral upper lid blepharoplasties, and that gets paid by MSP when there's a field defect meeting the top 20 degrees. Artifacts, that's a very important thing. I get a lot of referrals for artifacts, and people tend to think, oh, it's glaucoma, whatever. So you have to look at your field properly. Your fixation losses, your false positive, your false negative, doesn't make sense. If you have a field defect, it's got to match somewhere. So if you think of glaucoma, there's got to be a cupping that matches your field defect. So one of the main causes of artifacts is lens rim. When you do visual field, your tech puts the lens too far away from the eye, and then you just see the edge of your lens, and it gets your lens rim artifact. So you need to be made aware of these things. Hysteria, fatigue, and attention could all. So your older patients that fall asleep, you need to wake them up, and obviously, or redo the test. And of course, the more visual fields you do, the better you get. It's like playing Xbox, I guess. So nobody's good at the first couple of visual fields. Glaucomas, to me, obviously the most important visual field defect, and these are kind of typical glaucoma visual fields. You got your nasal step, which is number one. Temporal wedge, it's not very common, I find. You've got your arcuate, which is the same as germs, superior or inferior. You've got your secocentral, and I'll go over these with some examples later on. Your paracentral scotomas, which are usually within 10 degrees of the central area. Your diffuse constrictions, which are kind of non-specific. It could be glaucoma, but it could be cataracts, it could be media opacities, it could be bad refractions, meiosis, whatever. So make sure you're aware of that. And also there are some diffuse losses as well associated with glaucoma. So again, the visual field loss will predict the area of damage. So I'm going to go over the macular sparing issue. What is macular sparing? So it's either a quadrantanopia or hemianopia from a cortical or occipital lesion where the central vision is preserved. And there's actually one theory. The other ones it's not really a theory anymore. The whole idea is because there's a dual supply, vascular supply to the macular regions of the cortex from the middle cerebral artery and the posterior cerebral artery. So if you have, let's see, a stroke from the PCA, you still have vascular supply from the middle cerebral artery. Therefore, you keep your that portion of the visual field intact. The other theory has been developed. Sometimes you can have a hemianopia without macular sparing. This is called macular splitting. The differentiation is important in the sense people that have macular sparing will do much better as far as their visual tasks. They can read a little bit. They can see the word. The ones with macular splitting cannot. So that's important to know. If this is you can read some words on your right page that you cannot if you have a full hemianopia here. Also, you need to patients that have that, you need to teach them, along with their spouse or their family members, what it all means, okay? So obviously somebody with a field defect like this obviously cannot drive, right? So hopefully you're telling patients that you're done with driving. But as well, I would not let people cross the street with people with a defect. You know, if you have a right defect, you don't see cars coming on your right side. You're going to get hit, okay? I would not cook. You don't see the right things on the stove. So you could burn yourself. You can, burn the house down. So I wouldn't let them use sharp instruments either. So that's important. And even going to the mall, they'll bump into people on the side that they're affected. So their significant partner should be standing on that side when they walk so that they don't hit anybody. So things that you have to remember. I'm going to present you some of our patients, some interesting cases with visual field losses. Glaucoma, retinal defects, neurological, etc. Oh, I'm sorry. Okay, yeah. The first case is a 58-year-old male. He's being sent to us for a diabetic eye exam. That's a lot of our patients are diabetic. And he had a history of keratitis, which is not an issue here. So we did an OCT, like we do an OCT in everybody. So if you see, your macular OCT is fine. But what's going on here with the OCT, and why is it red? Right? That means there's some thinning, right? But does that look like a glaucoma cupping? It does not look that to me, okay? So that's kind of weird. But when you look at him, he's got a cupping of about 0.2. Guess what he has? He's got optic nerve head drusen. This is what you're seeing here. Little mountains. So instead of a valley, you've got a little mountain. And it could be much, much higher than that, by the way. But there's some thinning here that is not there on every case. So that's significant. So what do? We do a visual field. So what do we have here? You've got a nasal step inferior, more obvious on the left side. That looks like glaucoma, correct? That's your typical nasal field. But his IOPs are normal, and the OCT doesn't look cupped at all. His cupping is 0.2 at most. So I don't think this is glaucoma, and we're not putting him on drops, but we are following this patient. So I'm going to talk a little bit about optic nerve adhesion. So typically, they are an incidental finding. Most patients don't come in with complaints. This guy didn't complain about anything. So that tells me he must have had that field loss for years, if not decades. Doesn't seem to bother him. What are drusen? They're really depositions of mucopolysaccharides and protein in front of the lamina cribrosa of the optic nerve. They're found in about 1% of the population, so it's pretty common. And they are bilateral in about 75 to 85% of cases. And this one was. There seem to be more common among Caucasians, and there may be a dominant pattern of inheritance, but that's not that clear. There are two types of optic nerve adhesion, the visible ones and the invisible ones, or buried ones. So buried ones tend to be more in younger people, preteens, and it's important to know because they will obscure the edge of your optic nerve and it may look like papilledema. So your job and my job is to differentiate one from the other. One is more benign, one is not. Okay, so it's important to know that. As they get older, the drusen kind of move forward and they become more obvious, more visible. And again, most patients are asymptomatic, but when they do have symptoms, they will often complain of peripheral vision losses. Again, this guy didn't have any complaints, but he does have some. And there are also some sometimes transient visual obscurations, such as flickering or graying out of the vision. So talk to your patients if they have symptoms that are similar to that. Rarely, they could have central vision loss if they have choroidal neovascularization, but it's not that common. So again, it's mandatory for you and I to rule out papilledema. And then I'll go over what needs to be done. Something that's interesting, and you need to know, what is the most common field loss in optic nerve adhesion? An inferior nasal loss. And this is what we have here. Okay, So this is a loss from the optic nerve adjacent. This is not a glaucoma loss. Okay, so don't freak out. Don't put people on drops, but follow them or send them to us. So what are some diagnostic techniques that we can use? Well, I showed you earlier the OCT, right? Pretty obvious little bump here. But again, I've seen people with, K2 looking like OCTs over there. So that's the first test to do. And it usually shows you the optic nerve adjacent pretty well. Angiography, these adjacent typically autofluoresce. So you'll see it with the fluorescein angiography, and they hyperfluoresce when you inject the dye. So we don't have it here, so retina will do that. CT scans, of course, as I said earlier, if you're not sure, neuroimaging may need to be done to rule out papillary edema. That's very important, right? So think about that. Last but not least is B scans. B scans can often differentiate optic nerve adjacent from papillary edema. I have a colleague, Dr. Awashan, who's a neuro-ophthalmologist. That's what she does. And I think it's helpful. We don't have a B scan here. Optic nerve adjacent can lead to some complications. So they can compress and compromise nerve fibers and the vascular supply, leading again to visual field loss, vascular occlusions, and sometimes images. The type of vascular occlusive issues that we can have is CRAO, central retinal artery occlusion, or CRVOs, which are central retinal venous occlusions. These can be seen because you have an optic nerve that's bunched up, and it's easy to get occlusions with that. They often are hyperopic, by the way. People that have smaller eyes than nearsighted people. Sometimes they can be associated with other eye disease such as RP, and so there are some systemic diseases such as pseudoxanthoma elasticum that can be associated with those optic nerve adjacent, and there is no treatment for this. Second case is a 63-year-old male. He's followed for glaucoma. He's got a cupping of 0.9, 0.95 in the right eye, and we're thinking of sending him for possible trabeculectomy. So this is your typical tunnel vision. Most of his optic nerve is gone. And you can see with the OCT is very thin on the right side. There's very little tissue left. The left eye is cupped, but there's no obvious thinning over here. So, and I believe his visual field was normal on that left side. So it's an asymmetrical glaucoma, which is good. At least he has one good eye left. Third case, another interesting case, a 56-year-old male. He's a black guy. And the reason I say that is blacks have more glaucoma and go blind faster than other races. So you need to be made aware of. So you probably want to be more aggressive with your glaucoma patients that are blacks. So this guy was followed. He was doing well. He's on drops. So this is his OCT. He's a little bit more cupped on the right eye than the left eye, but and a little thinning here, but nothing terrible. So we do with a visual field in, I think that was 2018 in January, which is normal. And one day he comes back. I don't do blue. Just a follow-up, his pressure on his right eye is 40. He's using his drop. He swears he's using his drops. Nothing has changed. I do gonioscopy. There's nothing going on. No narrow angles, no neo vessels, nothing. Totally out of the blue. And that's why we follow people regularly. Just because they're doing well doesn't mean they'll be doing well 3 months from now. So we did another visual field, which was a few months later. And he's got concentric a loss, a peripheral loss, which wasn't there just a few months ago. Okay, so, and I believe this is from his IOP spike that he probably had this for a few weeks before we found it, and he's already got some losses. And I think that's probably what we're seeing here. and it may get worse with time. And I think I sent him for a